want to just up front say how delighted AASLD is to partner with TASL in this symposium. And indeed, I hope it's one that we will continue to share and build upon in the years ahead. And I know on behalf of all of those that are attending for the AASLD today that we're all delighted with just being in Taipei and the really wonderful and warm welcome that you've given us and showing us Taipei. So we're really having a terrific time. So thank you. I've been asked to talk about the sort of the path to viral hepatitis elimination, and I know that there's going to be a talk that follows that looks at more specifically Taiwan. But let me set the stage. This is data you all know very well. That the WHO several years ago now set these very ambitious goals for us in terms of elimination by 2030. What it means in terms of the viral hepatitis is that we want to see a 80% reduction in new infections for hepatitis C and a 95% reduction for hepatitis B. And we want to see reductions in mortality of 65% for both viral entities. You'll also see in the table at the bottom that there's also elements related to prevention, especially mother-to-child transmission, as well as elements related to vaccination. But part of this is also the importance of treatment, and I'm going to be focusing on that specific aspect of elimination, but not to discount that other aspects related to prevention are equally important. Now, in general, I think we all feel like we've got so far to go in terms of elimination, but there have been successes already. There was a publication this year that looked at global mortality related to viral hepatitis, and indeed, from 2015 to 2019, global mortality for hepatitis B and C has declined. For hepatitis B, it's declined by 7%, and for hepatitis C, a really quite striking 28%. So you can see that we are indeed making progress. But mortality still remains high, and particularly in certain areas. So shown on the right is mortality by virus and by region. And I'll highlight that the Pacific West is in green, and you can see that, of course, there's still a fairly high mortality from hepatitis B, really making it more than half of the mortality from that was reported in that area. And for hepatitis C, it's a little bit more evenly distributed. Interestingly, in terms of global deaths from viral hepatitis, the Western Pacific region is thought to have about 50% of the global deaths. So still a very important problem for this region, but also one that we are still struggling with in the United States, where we too are really working hard to try to get our elimination underway so that we can see these drops in mortality. Just to give you one other bit of global data before I do kind of a deeper dive into the treatment, is that the GHSS also set targets for treatment, and for 2020 their goal was to have 5 million individuals with hepatitis B on treatment and 3 million with hepatitis C. So again, if you look at the table, in terms of meeting that goal, that we were successful. With more than 6 million individuals with hepatitis B being treated and more than 9 million with hepatitis C. But also emphasized by this table is that there's a lot of variability by region, and then even within regions, there's variability by country. So actually the majority of the countries are not on track to meet the elimination goals, and many of them are faltering from the point of view of preventing new infections and in meeting these treatment goals. So now I'm going to focus on the challenges and some thoughts about how to move forward from the point of view of the HCV component. So just to highlight that when we think about the cascade of care for hepatitis B and C, first and foremost, you have to make the diagnosis. And where you can see in both figures is where our biggest challenge is that we still haven't diagnosed the majority of the individuals who are infected. So for hepatitis B, globally, only 14% of patients have been diagnosed. For hepatitis C, it's somewhat better at 26%. So I can talk all day about how we got to get more people on treatment, but first and foremost, we need to find those individuals and get them diagnosed. That's key. But then you can see that also for treatment, we're also have big gaps. Only 8% of treatment-eligible Hep B patients have thought to be treated, 16% for hepatitis C. And so I just want to, one more time, the lack of awareness is our first major issue, even though I'm not going to spend more time on it, but that still remains the big one. And then the other, I think, kind of unexpected challenge that we've had, especially for hepatitis C, is that new infections are continuing. Less so for hepatitis B, where we have a vaccine, but in the absence of a vaccine for hepatitis C, the number of new infections is starting to outpace the number of people being treated. So, for example, in 2019, there were more than 3 million new chronic infections from hepatitis C, and you can see there throughout the world. And in the United States, for this year, for example, for the first year, we have more new infections than we have cures, and so the prevalence of hepatitis C in the United States didn't change this past year. And many other countries are facing that same challenge, where the new infections are really what's leading to our major challenge from the point of view of elimination. And for this reason, the WHO in mid-2020 highlighted that if we're going to get to elimination, we have to acknowledge the high-risk groups that are getting new infections, both hepatitis B and hepatitis C, and target those individuals for very specific diagnosis and a test and treat approach. And the 5 groups that they identified are persons who inject drugs, men who have sex with men, those in judicial or prison settings, sex workers, and trans and gender diverse individuals. And so they very much highlighted that if we're going to get to elimination, you cannot ignore these groups of individuals. This is where the new infections are occurring. So in terms of the prospects for making gains in elimination, I'm not going to talk further, but just to emphasize prevention of infections is going to be really critical. So it's not just treatment, it's the prevention piece. Secondly, if we're going to really get people to treatment, we have to diagnose them. And there's an increasing emphasis on point-of-care testing as a way to get to more individuals who can be diagnosed. And then what I'm going to focus on today is really the treatment piece. But also part of elimination is that we have to think broadly about who can do this cascade of care. It cannot just be hepatologists, even though we should still be major players in this arena. We need to build out capacity to do diagnosis and treatment among front care workers. And so the kind of terms you're going to hear a lot of, and I think warrant focus, is we need to decentralize the diagnosis and treatment, we need to integrate it into other aspects of general health care, and we need to task shift from specialists to primary care. All right, so let me just talk really now a little bit more specifically about hepatitis B. So again, this is just that cascade of care. It's a slightly different set of numbers. This is done by Homi Razavi and his group. But it's the same. Again, 12% of individuals with hepatitis B have been diagnosed globally. But what I wanted to focus on in this element now is, of those that are known to be infected, how many of those that are treatment eligible are on treatment? So that's what this box is showing you. And what it highlights is even in those where we have made the diagnosis and they're in care, there's still a gap between those individuals who are eligible for treatment getting treatment. And that number is, on a global basis, only 40% of individuals being treated. I'm going to show you some US data just to say that even in the US, where we have access to diagnostics and we have access to treatment, even in the United States, only 50 to 60% of individuals who are eligible for treatment are on treatment within a year of that eligibility. So there's this gap of probably 40 to 50% of patients, maybe as high as 60%, who should be treated and are not being treated. And there's probably a lot of reasons for under-treatment. And this is, I think, something we need more work done on, but I'm just highlighting some of the areas that have been highlighted. First of all, there's a stigma associated with kind of having hepatitis B in certain parts of the world. That stigma holds back individuals from potentially seeking care. There's also a lack of knowledge about infection, the importance of being treated, and then there's an issue in terms of adherence to monitoring. That could be related to costs and or just convenience. On the provider side, probably a lack of access to specialists who really know all the guidelines in great detail, that is probably a barrier to getting treatment. Then I think the knowledge about the guidelines and their changes has been highlighted, and probably the one that gets the most press these days is that the guidelines are too complicated for individuals to implement. And then we have to consider that there's some system issues. For example, if there's not a national program that supports diagnosis and treatment, that can be a barrier. There can be barriers on the part of the patient not having funds to be able to pay for certain drugs, for example. And even the monitoring in some parts of the world can be a barrier, where the cost of doing HCV RNA testing, HBV DNA testing, for example, is a barrier. So all of these collectively are contributing to the global issue around undertreatment. But what I'm going to spend a little bit of time on is this complexity of guidelines, because I think in countries like the US and in Taiwan, I think where perhaps we have good systems in place to do treatment, the question is, does complexity contribute? So what is the issue around this complexity? Well, Hep B is a challenging disease to treat because it's dynamic. It's not like hepatitis C where you make the diagnosis and you just treat. Here there's phases of activity, there's phases of inactivity. And so if you see a patient today and they don't meet criteria, we don't know, is that going to be still the case in 3 months, 3 years, or 3 decades? It's going to change, and this need for monitoring and ongoing assessment to make a decision about treatment can be a challenge. It's a challenge for the providers, it's a challenge for the patients to be adherent to all of that monitoring. And that has been proposed to be one of the reasons why undertreatment occurs, is that we're missing the opportunity to initiate treatment when a patient meets eligibility. The second is, of course, that, and we'll go into this in a little bit more detail, is this question of gray zone patients. And that people in the gray zone we don't recommend treatment for, but perhaps that's a group that should be offered treatment. And then third is that there's a lot of variability across guidelines. AASLD is different from EASL, is different from APASL, is different from the country-specific guidelines. So that also, I think, creates confusion and perhaps complexity. So just to highlight the AASLD and APASL guidelines, we're actually aligned in terms of what we currently say about who should be treated. Basically, you need to know 3 things: the E antigen status, HBV DNA level, and ALT. But you see there's other things that you also have to be thinking of. The stage of disease, do they have cirrhosis, are there any extrahepatic manifestations, what's their histological stage, and do they have any family history? So you can see that if you have to think about all of those things, and you're not somebody who's deeply invested in Hep B, it may appear confusing or complex. And that has been the comment made, that if we want more frontline workers to do HBV care, we can't have this kind of an algorithm. The other thing that's been highlighted is this gray zone issue. So I show here just one study, there are many, but generally about 1 in every 4 patients when they present is in the gray zone, meaning that they have an ALT level or HBV DNA level that doesn't meet the thresholds for treatment. It turns out that most of the gray zone patients are E antigen negative, and that most of them actually stay in the gray zone. So then we have these patients that year after year are sort of in this area where we're not sure if we should treat or not. That also creates complexity and probably contributes to undertreatment. And just to say that the gray zone patients, now we are getting data that suggests that untreated gray zone patients may be at risk. So this is a very nice study that was recently published, in which you'll see most of them are E antigen negative, but 21% were E antigen positive. These were all patients that met the definition for being in the gray zone. And then some of them were treated by their physicians and some were not. And then they just looked to see what were the outcomes of these patients. And what they showed is that with a 10-year horizon, that there was a higher risk of HCC in those that were in the gray zone and remained untreated versus those that were treated. And that's, you can see the hazard ratio, it's about a 70% difference in terms of the rates of HCC, although overall the rates are low. So I guess this would suggest that the gray zone patients should be considered for treatment, but I will highlight that there's a letter to the editor that highlights the thing that we have to always be thinking about, is when you have a 10-year horizon, you have to think about, was a patient, were they in the gray zone throughout that period of time, or was there a missed opportunity where they qualified for treatment and didn't get it, right? So that's a different problem, but still one that we have to wear up. And in the letter to the editor, what was said is that the risk only increased in this cohort after 5 years, raising the question of whether it was a loss of monitoring capacity after 5 years versus a true increased risk of HCC. Of course, you're all very aware that the Chinese guidelines in 2022 have really moved very rapidly towards let's make it simple. They've made it simple by eliminating the consideration of e-antigen status, and they're really largely basing it on HBV DNA level, and to some extent age and non-invasive markers of fibrosis. So this is a very different approach than the very complex AASLD and current TASL guidelines that I just showed you. So is this the way of the future? Is this the way to elimination? I would say, I'm not sure. I think it's what's in favor of doing a treat all or treat most type of approach is clearly we have drugs that are highly effective, they're generic and generally inexpensive. If you put somebody on treatment, it reduces this likelihood you're going to miss the opportunity to treat, so that's important. Very relevant is that by treating viremic patients, we can prevent transmission between individuals, and that's probably relevant for especially young adults, for example, or those that are in high-risk situations. It's believed that maybe this would reduce stigma, and I'd say may, because I don't think we have solid data yet, it may reduce your risk for liver-related complications in the future. Now, on the con side of this approach of treating most or treat all, is that we really lack the data to say that there's a treatment benefit for every patient. For example, those that are for example, immune tolerant, that truly are immune tolerant, what are the benefits to those in terms of their liver-related complications? Not well established, I would say. It doesn't completely eliminate the need for monitoring. Not all patients want to take a pill for life, and adherence is going to be an issue. And that's the one thing I'll just spend one more slide on. And then just that cost could be a barrier for some individuals. So just to say a bit about adherence. So if we put everybody on treatment, we need them to be adherent. And even currently with the way we do very targeted treatment, we're seeing that there are issues with respect to adherence. So in this study on the left, this showed that there was in this cohort a lack of adherence. And what you can see is those that are non-adherents then actually are at risk for complications. Even in the United States, again, where we have a lot of emphasis on kind of education and really close monitoring, 35% of patients non-adherent or low adherence, and at least 79% they said they had missed medications between visits. So clearly, if we're going to move towards a treat-all, we have to do a lot better job on patient education. So in terms of the HBV treatment and meeting elimination goals, I just want to emphasize 4 elements. One is this large gap in diagnosis and awareness, so we need to fix that. Secondly, I do think we need to simplify treatment algorithms, whether it's going to be, as has been done in the Chinese guidelines, or something more intermediate. Clearly, that's important for increasing treatment capacity. I do think this concept of treating to prevent transmission to others has not been the focus and should be. So that's an important element. And then this idea of adherence is something that's really relevant to getting the treatment benefits is the final box there. And then in the last several minutes, I'm going to just focus on hepatitis C. So here's where, by contrast to hepatitis B, the treatment guidelines are super simple. It says treat everybody. So it's very easy. Whether it's WHO or AASLD or EASL or PASL, it's all the same. Treat if you have somebody who's infected. What's been the focus is really a move towards doing more test and treat, to treat patients where they are, to reduce the likelihood that they're going to fall off the cascade of care. So what the WHO is emphasizing now, and what I think most countries are focused on, is how do we do a simple point-of-care diagnostics, have a simple tool to stage them, and then just do treatment. And a very sort of simplified algorithm, test and treat, all done in one visit. That is the goal. And there's data that supports this idea of test and treat and very minimal monitoring. This is the MinMon study, which was completed and published last year. This is a study that showed that minimal monitoring can work. These were done across many different research sites. Some of them were ID clinics, some of them were kind of more smaller clinics that typically took care of patients with HIV. But in their minimal monitoring approach, what they did is they didn't require genotype. They dispensed the entire treatment course all at once. So the patient, when they started treatment, got 3 months of soft val. They didn't do any monitoring during treatment. They just did one remote visit at week 4 and then one more toward the end to tell them to come in for their SVR visit. So very minimal monitoring here. And what you can see is that the vast majority of patients reported completing all of their medication and their SVR rate is exactly what we would expect. So this tells us that we can do HCV treatment and we can do it with very minimal laboratory monitoring. And then this concept of really taking treatment to where the patients are at. I show you just one example of a test and treat model from Myanmar to just say that globally this is the approach that's being taken. These were 2 community clinics, one of them serving persons who use drugs and the other chronic liver disease patients. And what they did is they offered an on-site point-of-care test, and then general practitioners made a decision about starting DAA therapy. They had a specialist available for evaluation if they needed it, and then they just prescribed. They had a time from diagnosis to treatment of 3 days in this setting. This is remarkable, right? And then what you can see is just the number that tested positive, first of all. Then they did the RNA test with the gene expert RNA, and of their individuals that they tested, 88% of them were viremic. And then what you can see is the vast majority of those individuals completed their treatment and got SVR. If they did a modified intent to treat, meaning that they looked at the patients who returned for their SVR12, their SVR rate is 92%, which is exactly where we'd expected. So this tells us that we can do this test and treat model in settings where patients are, community clinics, in clinics that serve persons who use drugs. And so really an important aspect of HCV delivery of care is the expansion of care to other providers. And there's lots of ways that we as hepatologists can support that development. That is our job, is to actually bring on the next kind of level of test and treaters in primary care. You can do it through the hub and spoke models of ECHO. You could do online or remote access as a specialist. Sometimes specialists go into these primary care settings, and now increasingly we're seeing pharmacists becoming central to doing treatment as well. These are all important models that are going to help us to get to elimination. And then I have to come back to this idea that where are the new infections? The new infections are in the individuals that are at high risk for really risk behaviors, persons who inject drugs, and probably MSM is the other big group. So we can't do treatment without thinking about doing prevention as well. And again, the WHO has really played into this by saying not only should we be thinking about doing the treatment, but also kind of the syndemics of, looking at whether they have HIV, check them for HBV at the same time. Think about how we're going to manage their drug use, for example, as all part of the package of ensuring that not only do we cure their hepatitis C, we identify the other viruses that might need treatment, and we deal with their addictions as well. And you can see that these are complex patients that often need broader healthcare support, mental health, pregnancy sometimes, even alcohol use. So this idea that we have to begin thinking more comprehensively, especially in these groups where the new infections are occurring, is key to elimination. Because if we don't do harm reduction, we will not be successful. And here's just one of many, many models that show if you do DAA therapy, for example, in persons who use drugs, and you don't couple it with harm reduction, that you really can't get ahead of the number of new infections. So if you really want to bring down infections in those high-risk groups, you have to do treatment plus harm reduction. Harm reduction would mean giving syringe, having syringe exchange, and treatment of, say, opioids addiction. So just to close, in terms of the key aspects of HCV treatment, I think key, again, most of the focus has been on having a national plan that it can ensure access to the diagnostics and DAAs. If you don't have that, elimination is very challenging. Remember that, where are the new infections? We've got to have targeted treating and prevention in those groups if we're going to stay ahead of the incident infections. There's been a big push, and I think we've made great strides for Hep C with respect to having a simplified cascade of care, and now a focus on a test and treat approach. And then finally, our role as specialists here, in contrast to Hep B, where I think we still play such a big role in making treatment decisions, but increasingly there too, we have to move towards sharing that responsibility for care with our primary care colleagues. So in terms of the pathway to elimination, I think just to kind of summarize the major bullets that all countries are working on, is we need to strengthen prevention, we need adaptable screening programs, recognizing where our new infections are. I think we have to think more about having accessible diagnostics and service delivery, an openness to simplified treatment recommendations, which is going to be probably most important for hepatitis B elimination, flexibility in monitoring and follow-up, building capacity to deliver hepatitis care outside of specialty practices, and then ultimately for any elimination program, you have to be able to capture what you're doing and know if you're making progress, so having support for data and reporting systems is key. And with that, I'll close. Thank you very much.